because this is not like GI anomalies, the kidney anomaly associated with a lot of genetic condition. Sometimes we, maybe one hospital invented a kidney panel, maybe the other country used a different one, or you use the point-to-point in for the gene sequencing for each gene, or you can use the whole exome sequencing for everything. So that would be more intense in the second half. Tion will be introduce some genetic aspect to everyone. So what is CAKUT? Is a congenital anomaly of kidney and urinary tract. It's 20 to 30% of all anomalies can be identified in prenatal period, because and it's 2002 papers. I believe now it's more and more fetal anomaly you can identify prenatally. The overall rate is 0.3 to 1.6 per 1,000 newborns, including live and stillbirth. 30 to 60% of pediatric and young adult patients with ESRD, which is end stage of renal disease, who needs lifelong hemodialysis. So congenital anomaly of kidney and urinary tract, it's raising the detection rate, as I said, because now prenatal and postnatal ultrasound exam, which quite routine perform, we done a lot. So if you do some kidney exam prenatally, you can easy to find. So abnormal ultrasound results in 0.2 to 0.8% of all pregnancies. The incidence in general population is around 1%, which is not very low. So there are two different categories. The first one is congenital nephropathy. This is about kidney. The second part is congenital uropathy. It's about ureter and bladder. So about nephropathy, including kidney agenesis or hypoplasia, this is most severe form. If you got kidney with agenesis without any blood flow, or hypoplasia, and then this kidney cannot be used, and it also associated with very few amniotic fluid with oligohydramnios, and the prognosis and outcome in this category is very poor. So part of our late termination cases are the kidney agenesis without any amniotic fluid. So we do the late termination and do a feticide and terminate. Then the other one is hypoplasia with dysplasia and oligomeganephronia. And also the other aspect is dysplasia type without cyst or with cyst, which is not much different. And multicystic dysplasia and obstructive form. Multicystic kidney is always good with normal amniotic fluid. It's always good. Then we go to down to the ureter pelvic junction stenosis. If you got ureter pelvic junction stenosis here, you can increase the potential of hydronephrosis. Or you go to primary non-reflexive megaureter, the ureter is increased. Or primary reflexive megaureter. This is distal ureter obstruction. And secondary megaureter with infravesical obstruction, which is urethral valve here, and meatus stenosis, which can induce bladder outlet obstruction, which called luteal. And in this case, with bladder obstruction, you need to do the fetal therapy. You need to do. This is the only indication you can do the fetal therapy. The other, no. You cannot put the needle into the kidney. No, it is not allowed to do that. The other aspect is ureter ectopia without doubling malformation of upper tract. Sometimes you got double uterus. Maybe you will have a whole-shaped kidney, or maybe you only have one kidney, or only one ureter, or maybe double vagina. So it's including the urogenital tract congenital malformation will induce a ureter ectopia, or like ectopic kidney as well. So this is the embryology of kidney development. As you can see here, from for nephrons, then to the nephric duct, then go to the mesonephrons. Then in the later form, it's mesonephrotic mesenchyma and ureter bud and nephrotic buds. Then this is initially it's cloaca. It's a common cloaca, including the genital tract and urinary tract. So this is published from 2011 Pediatric Nephrology. So the weeks of 5 to 6 weeks, you can see this is urinary bladder budding. Then this is right side kidney. Then the common shape of nephron, the S shape of nephron, and the endothelial cell. Then they are starting to looping looping to into the collecting duct. Then go to the formation of the kidney. So in the 4 weeks and the 5 weeks, you can see the ureter and the kidney shape already down there. And if you see this apoptosis, then they getting close, then the lobby is spread. Okay, this is the other abnormal kidney development like this. In 5 to 6 weeks, renal agenesis formation very early. And if a renal hypodysplasia is something like this, renal agenesis, which means no kidney, you can't even see the kidney. And renal hypodysplasia is poor function, is around this stage. And in the data end stage, this is urogenital sinus, and 4 weeks, 4 to 5 weeks, and this triangle of the trigon of bladder, and the left side right side kidney here. And this is the other aspect of embryology. So we can do prenatal kidney urinary tract imaging. So urinary bladder and kidney can be visualized by ultrasound from 12 weeks. So if you have a 12-week scan, the scan machine need to be very nice with high resolution. Then you can see the kidney formation at as early as 12 weeks of gestation age. For the cortical medullary differentiation, starting from 18 to 20 weeks. So if we want to see more details of the kidney, we usually arrange anatomical scan at 22 weeks, right? Then you can do the kidney urinary tract differentiation very clearly. So screening ultrasound for congenital malformation at second trimester of pregnancy is usually like 20 weeks around. So you can do the first anatomical scan for all the organs of the fetus. This is the image for the kidney. You can see this is a normal kidney. You have to measure the size of kidney in the transverse form, and you can measure the kidney pelvis, the size of the pelvis. So in the upper part, you can see this is called what? This is what? This is polycystic kidney disease. It's called we got ARPKD, autosomal recessive, and also we got autosomal dominant. And the formation is very similar. It's like the kidney is polycystic, and the prognosis is very, very poor. I got a lot of these cases, and we do a lot of normal gene mutation study, because the Taiwan population is also different. I'm sure to different countries they will have the different genetic condition. So you can see the kidney is like homogeneous formation. Sometimes we have a lot of cysts, but the condition is you can't see any amniotic fluid. If you want to test, you can inject. We can do the amnio infusion into the fetus. Then after you inject 300 mL, but you will find the amniotic fluid will be gone in the next day. On the next day, it will be totally gone. It's not leaking from the vaginal. It's just gone. So in this case, condition was very, very poor prognosis. How about this one? This one is multi-cyst kidney. You know that, right? MCKD. This is PCKD, it's the MCKD. For the MCKD, you can see different. The amniotic fluid is very nice. And usually it's one side, unilateral side affected. The other side you will have a normal one. So don't worry about this kind of type of disease. You can counsel the patient. Usually you can encourage them to deliver the baby. Then at least they have one normal kidney function, can have a normal urination. So information from gynecologists, what we have to do. We need to do the interpolar kidney diameter for both kidney. And we also need to see the position of kidney. Usually, if you go to the AC view, the cross with stomach, then you go down a little bit, you usually can see the both sides of kidney. Then cortical medullary differentiation and aspect of renal parenchyma as well. And then we need to see the dilation of the collecting system, like renal pelvis. We can see the grading of hydronephrosis and ureters as well. The last part, we need to see the presence of dilatation of urinary bladder. Usually, if you scan 30 minutes, you will see the bladder coming up and becoming smaller because the fetus have a urination of the bladder. And we need to see the amniotic fluid, to see the amniotic fluid index or DPS spark. So we diagnosis of the CAKUT is the aim of prenatal consultation. If that is isolated, unilateral or bilateral or syndromic, so it's all different. You have to see this is isolated or with the other multiple anomaly, which is completely different. So we have to predict a prognosis. In the pregnancy, termination of pregnancy is 4% in isolated. But you can see it can be up to 50% in syndrome cases, including everything, including maybe genetic condition, chromosome condition as well. So indication for fetal surgery is only in bladder, is in luteal bladder outlet obstruction. So indication for delivery is better delivery in the tertiary center, like I said. So the child survival and renal outcome you need to follow up and postnatal treatment. So this is a paper from the European Journal of Medical Genetics. You can see prenatal diagnosis of this. This is a dilatation of upper tract, and number of cases diagnosis from the top 4 is dilated upper tract, and unilateral multicystic dysplasia, 11%, and unilateral renal agenesis 4%, bilateral renal agenesis 9%. So the total number, total cases detected is 82 detected prenatally, right? Total number, you can see. In number of detected antenatal is 259, but number total is 309. So the detection rate is very high in dilatation of upper tract. And unilateral multicystic kidney, the detection rate even higher, like 100%, 97%. And also bilateral renal agenesis is 91%, which is very, very high detection. Which means overall detection of all kind of kidney urinary tract anomaly is 82%, which is very nice. You know, this is very nice. All the kidney disease you can detect 82%. Then this is hydronephrosis, which quite common, 1 to 5% in general fetal population. So sometimes we can just see the fetus in ultrasound with dilated hydronephrosis, which is quite common. But we have to see the different grading. Its classification from the Society of Fetal Urology. The first grading is like this. It's usually barely split sinus. It's quite normal. It's barely split. The second grade 2 is a full pelvis, but major calyx dilate. It's like a finger budding, like a budding, like this. So in this is grade 2. But in the grade 3, which is very abnormal, you cannot see, you cannot miss this grade 3. It's uniform dilated minor caries. Minor major caries is dilated, budding like a big tree. You can see that parenchyma spared. But in this one, the parenchyma compromised. This is the kidney is poor function. It's normal function. So pediatric classification, you can see we normally I normally personally use this classification. I mean over 0.4 centimeter, which is 4 millimeter, is mild, and over 7 millimeter is moderate, and over 1 centimeter is severe. So I usually use this classification, or you can use a third trimester, but you must add some more millimeters here. This is classification distance, and also grading. Grade 1 is mild, grade 2 to 3 is moderate, grade 4 is severe. Okay, then we have to know the prognosis of antenatal hydronephrosis, right? So in any pathology, in a severe form, it's 88.3, yeah, 88.3. I mean, the most common cases is mild form, and moderate to 35. So they published this paper in Pediatrics 2006, meta-analysis of 1,645 studies. In study, 17 studies included. Yeah, so in a severe form, you can see in any pathology, in a postnatal pathology confirmed can get 88.3%, which is very high. So in a severe form, you cannot miss it. Then you can diagnose a lot of cases. For the termination of pregnancy, the number we can starting from this bilateral MCKD. This is only 2% bilateral, but unilateral you should not do the termination. But bilateral renal genesis is 5%. They do the termination, including the 5% of case. The very large case is luteal, is obstructed bladder outlet obstruction, is 18%. Then the vector association is quite severe. The vector is including the multiple organ involvement. So in the vector, it is not suggest to keep the babies. Then bilateral renal hypodysplasia, which is quite rare, and also the ARPKD, coacal dysgenesis, metabolic renal disease, genetic syndrome, and other major malformation with renal pathology. So this is a classification of the termination of pregnancy in this classification. So we see cases here is a G3P2, 2 healthy children already. This case got 25 weeks, male, severe oligohydramnias, no hydramnia, and also severe hydronephrosis, as you can see, right? Bilateral hydronephrosis. It's grade 4 and megacystic. So this is the luteal. You can diagnose the luteal with a very important sign, which is something like a bottleneck here, right? This is the outlet obstruction here. So we'll see a bottleneck. So what you can do is termination of pregnancy. If you don't want to termination of pregnancy, you cannot leave the baby like this till birth. The kidney will be very bad after birth, right? So you need to do the fetal surgery, like you need to put a shunt into here to drain the urine out of amniotic cavity, or you just termination of pregnancy. That's why the luteal is the first indication of a termination. Okay, so at 25 weeks, this patient has been offered the placement of vesical amniotic shunt, and then start to increase of amniotic fluid then spontaneous delivery is 33 weeks. But you can see the birth rate is 2.4, the upper scale 8 to the 9. But the postnatal period is with pneumothorax, mild lung dysplasia, and ureter, but no VUR. And renal function at 1 week it's okay, creating 2.3, a little bit increase. But the treatment is we need to do the postnatal urethral valve resection, and we need to do the intermittent we need to do intermittent castration, and we need to do the antibody prophylaxis, and we need to do the intravesical oxybutynin and supportive care for the CKD. So we save the baby, but baby still need to have some medical further treatment even after birth. Especially you need to do the urethral valve resection to get the things out. So the GFR at 2 years is around normally like it is 58, which is okay. So the GFR is okay. Okay. So the other paper published here in meta-analysis of biomedical US ultrasound parameter to predict postnatal function in congenital lower urinary tract obstruction, which is more like a LUTO, lower urinary tract obstruction. So they found the best predicted value is renal cortical appearance. So if you have lower urinary tract obstruction, then you get very, very severe. You got severe hydronephrosis. Then your kidney, both sides, they get very severe distorted. Then you can see not any renal cortical appearance. Then you can say the prognosis is very, very poor. So the sensitivity is 81% and specificity 59%. So the renal cortical appearance is the major predictor marker for the prognosis of congenital lower urinary tract obstruction. Okay, so indication for the fetal surgery, as I said, is only in lower urinary tract obstruction, which is called LUTO. The stent is quite standard. We can use the Harrison bladder stent. We got 2 loops inside, 1 loop outside. Then you can relieve the stress here. Then you can improve the kidney function. So let's see the result of P-LUTO trial. They got 31 pregnancy with this indication. They got 16 shunting studies. This is the result. And they got a conservative treatment, just observation. Then we can see they got 1 in IUFD, 1 demise, and 3 termination of pregnancy, 2 termination of pregnancy. And they got 4 deaths less than 28 weeks. They got 8 deaths less than 28 weeks. But the survival got twice compared to the conservative treatment. They got 8 survival and 4 survival. And got 2 normal renal function, but 0 normal function. If you have the cases without any treatment, just conservative after birth, the renal function, zero case with the renal function normal. So that's why we need to do the fetal surgery for the LUTO cases, which is lower urinary tract obstruction. We seriously need to do the fetal surgery. So what is the indication for delivery induction? It depends on every single case. If the case you found the amniotic fluid is decreasing, and of course you got severe oligohydramnias, you better deliver a baby before 34 weeks or 36 weeks. Don't put later than 36 weeks, and you will improve the fetal outcome. And also you need to indication for delivery in tertiary center. It's like the others, the morning I said. Every kind of congenital anomaly babies, you need to deliver in tertiary center with pediatric surgeon ready to back up you. Yeah, especially if the kidney need to be done the renal replacement therapy immediately after birth, and also a complex surgery in neonatal period. So So what is the standard examination? For now, we do the prenatal diagnosis like every day. The standard examination is a 2D fetal ultrasound. We need to see the kidney length, and we need to see the grade hydronephrosis, anterior, posterior diameter, and ureter width. And we need to see the bladder diameter and aspect. We need to see everything, bladder, kidney, and also amniotic fluid examination. And we also need to see the fetal serum and urine. But this is not routines. We seldom using the needle to get the fetal urine to check. We seldom use this one. But for the advanced examination, I think 3D ultrasound will be helping, and fetal urine production, fetal cortical blood flow, and fetal MRI, and proteomics, metabolomics. But this one is not quite. This one is not standard. So you need to have the standard examination first. Then you need to do the second advanced examination to confirm your diagnosis before birth. This is 3D ultrasound, but I believe everyone can do this. This is not very difficult. Then you can see the different angles of the hydronephrosis, and you got the volume of the different grade of hydronephrosis. And this is the 3D ultrasound as well. This is using the volume data to see all the urinary tract, the morphology. But this have some limitation. It's lack of standardization. Methodology is different by different operator. Maybe I do the same one, you do a different one. And lack of validation, normal value, and data analysis and storage, which is quite different. So this is a reference curve for 3D renal volume. It's some paper published here. You know nuchal translucency, right? Like 10 years ago, I was thinking to make a 3D volume of nuchal translucency, and now I collect some paper and I submit to the prenatal diagnosis and be accepted, because no one do this. But then if you have some data, you need to draw this normal curve to tell others what is your normal curve. So if someone want to measure your 3D renal volume, and you can follow your curve. This is this is 3D ultrasound. And the other one is fetal urine production. You can see the urine foreign potential is decreased fetal diuresis might predict kidney function. But it's also lack of validation data. You can have the bladder volume before and after urination. Yeah, before and after. And this is kidney perfusion is quite important. I personally very think this is quite important. This is not 3D. This just you can just put a flow on the kidney blood circulation. You can see the peak systolic velocity, and you can also see the flow velocity in the kidney. If you cannot make sure if this kidney is function, or maybe you saw it is very small kidney, and you put the flow and no flow in, then you can sure this kidney is out of function. It's quite easy to confirm. And also we have a normal fetal kidney perfusion is a reference line. Yeah, here it's a PSV to see the flow data. So the conclusion is we need to interaction between gynecology and the pediatrics for prenatal diagnosis of kidney urinary tract disease. Prenatal consultation aim to make diagnosis and define severity and prognosis. We need to tell the parent your disease of kidney and bladder is good or is a very poor prognosis, and you need to have the pre and postnatal follow-up and objective information for the parents as well. So good prognosis markers for renal function outcome are limited, but are subject to intensive research. So someone want to make a good prognosis factor prediction, and you can do some intensive study to make all the parameters into your data set, and you can see the renal outcome. So you have to watch the renal outcome as well. Work with pediatric. Should be involved in and follow patient with some CAKUT. Okay, I think we can make some brief 5 minutes, 5 minutes rest. Then we go for more tough stuff. This is all about gene. Yeah. Any questions? Yes, please.
Dạ, em có một cái câu hỏi đó là những cái trường hợp mà CAKUT đó mà ví dụ như là không, thầy nói là cái good prognostic marker không có, thì với một cái trường hợp mà mình nghĩ là nó có tắc nghẽn đường niệu dưới mà xuất hiện sớm, thì ngoài cái chuyện là mình chỉ thấy một cái bàng quang to thì không thấy gì hết nữa, thì những cái trường hợp đó là cái ý kiến của thầy trong cái việc can thiệp như thế nào, can thiệp ở thời điểm nào? Ví dụ như mình có thể can thiệp fetal scope ở thời điểm sau 16 tuần đi, thì nó khi mà mình can thiệp đó thì nó có thay đổi cái outcome ngắn trong thai kỳ cũng như là về sau chức năng thận hay không? I have a question on your idea about the intervention of low urinary tract obstruction in the fetus. So, because you say that we don't have any good prognostic markers, for example, in the first or second trimester, we just see a megacystic endosome. So, which is the time you choose to do the interventions? Right after 16 weeks, or just wait until you see the dilatation of the upper urinary tract? How do you decide which time you will do the interventions? And does the intervention change the prognosis short term and long term even after birth?
Yeah. The timing of luteal is very important. For example, if you have if you found megacystic in the first trimester scan, like 13, 12 weeks, the prognosis is always very poor, especially the megacystic over 7 millimeter, which is very, very big, and in a small baby, and this always associated with chromosome anomaly, always, and you can just terminate. But in around 16 weeks to 20 weeks, which is early luteal presentation, in this case you can see the kidney function. If you can see the kidney is going to the grade 4 or grade 3, grade 4, then you need to do the early intervention. If the kidney looking fine, still fine, and still have some urine with normal amniotic fluid, it's just partial obstruction. You can see the bladder is quite dilated, but it's partial obstruction. Still can have some urine out. You can wait a bit, waiting to the 30-something weeks, then you can inject the fetal shock. You can also do the fetal scopic to dissect the valve, urethral valve. But I personally think that's too trauma, because you need to insert a fetal scope, which is more bigger, and you need to have a dissection, which is more bigger. The prognosis, I read about the summary, which is no different. So I think luteal is quite standard using the shunting. It's easier.
So in luteal cases, does the vesical amniotic shunting change the prognostic after birth?
Yes. Yeah, because if you do the shunting and the shunting still there, they release the urine and out of the amniotic cavity directly. Then you also release the pressure of the kidney. Then the kidney parenchyma will keep much better after birth. Yeah. Then later you can just go for the urethral valve dissection after birth, like this case. Yeah, like this case. He's got luteal at 25 weeks, right? 25 weeks, and they got bilateral kidney grade 4 already. You can see it, one kidney. And you can see the severe oligohydramnios is no more amniotic fluid. And this is you can do the termination of pregnant or do the fetal surgery. This case causes vesical amniotic shock, then increasing the amniotic fluid. But after birth, this case after birth, postnatal period, they found urethral valve but no VU reflux. So they got postnatal urethral valve resection directly. But still need to have intermittent catheterization, and you need to do the intravascular oxybutynin injection and antibody prophylaxis for the UTI infection. So it's quite standard.
And at the time you do the interventions, you just put the shunting, and do you do any investigation for the amniotic fluid, for example, the measurement of the iron or something, potassium or something like that? Just put the shunts or checking anything else?
No, currently we just do the shunting, but it's quite standard. If you want, you can do the urinary blood sampling. Then you go for the electrolyte study, like potassium, sodium. You can do that. Yeah, you can have some data if you want. It's very easy to have that.
In the FMF Congress last year, the Vilablo Kataya had the presentation or the indication for Luto, and she said that the best candidate for the Luto is the longitudinal, but the volume is over 12 millimeter, and the
over 1.2 centimeter, right?
12
millimeter.
12 millimeter.
Yeah, it's
yes.
1.2 centimeter. Yes. Yeah.
And no abnormal chromosome.
No abnormal. Yeah, of course. Yeah.
And without the umbilical cord cyst.
Yeah. Yes, without umbilical cord cyst. Yeah, very nice. Thank you. Yeah. The chromosome need to be normal, otherwise you cannot do this intervention.
Thì năm ngoái mình cũng đi dự cái hội nghị FMF, thì có cái bà Vilablo, bà bảo là cái chỉ định cho mà mình làm cái Luto ấy là mình phải không bị cái bất thường về nhiễm sắc thể. Thứ hai nữa là mình đo cái mix sagittal, thì mình xem cái chiều dài của cái bàng quang ấy nó phải quá 12 mm mới có chỉ định. Và một cái quan trọng nữa là không có cái nang của dây rốn. Bởi vì người ta nghiên cứu rằng là nếu mà có nang dây rốn thì chứng tỏ là sẽ có là nó là một cái complex, một cái complex disease, nghĩa là có những cái tổn thương khác mà mình không phát hiện ra được.
Tell me any comment in the first half of this section?
Yes. During the years there have been a lot of small changes in the way we understand this. From the beginning, we were quite invasive, measuring the electrolytes, natrium, calcium, and so on, macroglobulin, even that. But many times we didn't have long-term studies postnatally. So basically, all the data have been gathered at a few centers. One center is SHOP by Mark Paul Johnson, who's been doing the big studies. From the French, in Europe, it has been gathered by Françoise Muller in France, very much so, because she's one of the big specialists about this here. But still, the long-term studies were not done. And when they were done, on a subset of patients, we saw that all the markers we were using are not very good at predicting long-term effect on the kidney function. So still today we can say that we don't have a good markers for good prognosis in the long term, for example. Because before we had not the data at all. So I could not say today, I would not say today whether it's meaningful to gather the electrolyte, for example, try to predict. And even so, some American groups, as you know, mostly from SHOP, Michael Johnson, they did serial measurements, because sometimes if you do the first puncture, say to measure the urine electrolyte early on, the first one you draw out, it's an accumulation of electrolyte and then gives the false value. So they will first do the first measurement and then let new production of urine happen, and then they will a second one here. But even with this approach, you cannot see, you can predict the long term. So maybe you can say maybe there's higher chance maybe they will be born alive. But this is not the aim of fetal medicine, to only have a live born. We want, of course, if we do intervention, that it has a meaningful in the long term, of course. So it's, to this that it's quite confusing, and that's the reason why there is still controversy, because many times what was lacking was the long term. Because why it was lacking is because you can imagine fetal medicine or obstetrician are doing something, and then someone has to follow the children long term. And it's just another specialty, you know. So it was completely lost for follow-up. That was the main reason why we don't have the data. As long as it is during pregnancy, we have the data. After birth, we're not taking care of those patients any longer. So this is another specialty, and then they were not involved in the studies. So it took very long time before we could get long-term studies. And it was people like Francois Buller working together with the Necker Hospital, because Necker Hospital is a pediatric hospital. So they had the patient to follow them on the long term. That's the reason why you can get the pediatric data. And SHOP, as you understand, Children's Hospital of Philadelphia, is again a pediatric hospital, but where obstetricians were working fetal medicine there. So today I could not tell you, you have to measure the electrolyte, for example. Although you have, before I was a proponent to do it, but we have not the long-term study. And as Stephen said, that's the reason why they're not measuring it in Taiwan. Maybe they decide on morphological criteria. It was to do that, and then okay. The most important is to understand whether the family are ready to take the risk, because you have to tell them you're taking a risk. And if they are, then maybe it's worth to put a shot. What do you think, Stephen?
You mean a shot?
Yes.
Yes, I think if a case is candidate, so it's suitable,
yes,
can be put a shot.
Em sẽ tóm tắt lại một chút. Ở cái câu hỏi của chị Thư Phương á, thì thầy nói là nếu như trước 16 tuần mà bất thường nặng ở thận, ví dụ như có một cái nang megacystic rất là lớn, khoảng trên 7 cm, thì tiên lượng khá là nặng và thường đi kèm với bất thường nhiễm sắc thể, thì mình đừng thì nên là dừng. Còn nếu như mà bất thường nặng và đánh giá là chức năng thận nó ảnh hưởng rất là nhiều, thì mình có thể làm can thiệp sớm từ 16 tuần. Còn nếu như từ 16 đến 20 tuần có tắc nghẽn nhưng mà chức năng thận vẫn còn thể hiện qua là còn nước tiểu hoặc là còn vỏ thận, thì mình nên chờ đợi đến khoảng sau 20 tuần, khoảng 20-22 tuần đó. Còn cái marker để đánh giá cái chức năng của thận thì hiện tại rất là confused, vì mình không có những cái nghiên cứu theo dõi lâu dài, đặc biệt là sau khi em bé sinh ra, cho nên là không biết áp dụng như thế nào. Có nhiều người ta có thể đưa ra cái ý kiến là làm lại nhiều lần, nhưng mà nói chung vấn đề quan trọng nhất vẫn là mình không có cái long term để đánh giá cái chuyện đó. Với lại có một cái câu hỏi hơi cụ thể chút xíu là theo kinh nghiệm của thầy á, là thầy đặt mà cái sinh mà bàng quang ối như vậy á, bao nhiêu ca, với lại là nó có bị tuột ra hay không? Tại vì mình làm khá là sớm, em bé thì lớn lên, bụng thì to ra, di động đá binh binh, thì không biết là cái tỷ lệ mà tuột cái sanh đó là khoảng bao nhiêu? Stephen Shaw, may I ask you a question that how many cases you already put the shunt in, and does it
How many cases?
Prolapse and is go in displacement into the amniotic fluid cavity or in the cystic. So the rate of displacement, yeah.
I done a lot of thoracic pleural effusion, but just a few of the bladder. I think maybe less than 5. I can't remember, but seldom cases in Taiwan have the bladder outlet obstruction. I don't know why, but we just have very few luteal. Or maybe early detection, just termination, because the luteal cases prognosis is not as good as pleural effusion. Yeah, but I did the placement. I'm not sure if you operate that before. It's very easy to, if you don't have your hands very steady, then when you take out the trocar, it's very easy to lose. Sometimes you lose in amniotic fluid. Sometimes you even stuck in the uterine wall. Sometimes you need to do the amniotic infusion first. Otherwise, you don't have any space, right? In that case, it's oligohydramnia. You have to do amniotic infusion first. And sometimes you will have the shunt in the bladder. You can see any kind of situation. For example, I done a lot of pleural effusion. It's shunting from the thoraco amniotic shunting, right? I done once the shunting, the stuff, the device into the chest wall once, and I also have 2 times experience. We got very good position initially, but the baby were moving, were grabs, and they take it out. Yeah, two cases. Yeah. Any more questions? Okay, we take 10 minutes rest?
Yeah.
Yeah, okay. Stage A downstream portal, and it's associated with renal cyst diabetic syndrome. And this is quite new gene, and just published 5-6 years ago. It's quite new. So we now see the other case example. This is a prenatal follow-up. It's a G2P0. It's IVF cases. I got 24 weeks male fetus, but you can see oligohydramnia and also bilateral hydronephrosis, grade 4. As you can see that this is typical grade 4, and also megacystic, and also dilation of proximal urethra. So it's a luteal again. As you can see, this is a luteal. Okay, you can see a bottleneck here. So we got a weekly follow-up and 26 weeks fetal serum, and induction delivered 34 weeks due to severe oligohydramnia. So this baby delivered 34 weeks. Then the birth weight is 2.3 kilo, 8 to 8. Postnatal examination, prenatal diagnosis confirmed, of course, is confirmed severe. Polyuria after placement of bladder catheter, renal function in 1 week is equated 2.3. So this case also done the urethral valve resection and intravascular oxybutynin and antibiotic prophylaxis, and ureteral implantation at 1.5 years. So they got very severe impair of ureter and supported treatment. So You have a diagnosis of prenatally, and then also you need to do the postnatal follow-up. So if you do the first case, like you do the shunt, this case you didn't do the shunt, so you will need to do the bladder catheter after delivery. So it's a two-case scenario. The GFR is also okay. This case is luckily with a normal urinary function. So if you wanted to predict the postnatal renal function in congenital lower urinary tract obstruction, this is very similar like a previous slide. It's including 13 cases. So the best predict value is also the same. It's renal cortical appearance, sensitivity 95%. Sensitivity 0.57 and specificity 0.84. So all the data studies showing if you want to do the prenatal follow-up or predict the prognosis, you have to see the urine renal cortical and the ratio of a cortical appearance is quite important. So we know if you want to see the amniotic fluid, you can see the core four-quarter index, right? It's 1, 2, 3, 4. You can summarize everything. And if the AFI less than 8 or less than 6, which is severe oligohydramnia, I think both of us know. I think you should be aware of this. It's very, very easy to detect. So sometimes you can just place on your probe and you cannot see any amniotic fluid, which is abnormal for sure. Yeah. So the kidney survival in the CAKUT phenotype, we can see this survival. The worst survival is posterior urethral valve, is luteal. You can see this the age in 20 years old, the kidney survival is less than 50%. So the worst case is posterior urethral valve. The second worst is the solitary kidney. The best thing is unilateral hypodysplasia. Multi-cyst kidney is also very nice. Horseshoe kidney is also nice. So you can see different phenotype with a different long-term prognosis in the late future. Okay, and the diagnosis of this kidney disease in 70% of pediatric patients, you can see the percentage of patients is reflux is the most common. You can see over 50% patient with reflux, and also few cases with hypoplasia, bladder anomaly, dysplasia 6 without cyst with cyst. This is a percentage of the anomaly. So not only the genetic condition, this is also the molecular mechanism for the regulation of the kidney budding. So including BMP4, this is quite important gene, and also the CRET gene, and also GDNF gene. I will show you this later. So why genetics in this congenital anomaly of kidney urinary tract patients? Because familial clustering observed in around 10% patient families. So if you look into this, you should aware this is kind of inherited disease. So you need to have the pedigree to ask the family history if you had any family have this kind of disease. So high frequency of kidney urinary tract anomaly in a systemic first degree relative patient with this. So you can see 218 index patient enrolled in this study, and new anomaly or diagnosis in 23% high first degree relatives, and also was in 129 first degree relative in 92 families, which is over 50% have a familial condition. Not only it's around 10% patients, and we also need to see this because if you do the monogene knockout to see the developed gene in mice, then we can easy to get. You knock out the gene, then we can easy to get phenotype with a phenotype very similar to a human disease. And we use the mice and we knock out the gene, and the mice present like kidney agenesis, kidney hyperplasia, double kidneys, or ureter anomaly, etc. So this is a common gene list. As I said, that's the gene I said before is BMP4, and also this is WT1. It's some transcription factors, some secret signal molecule, and receptor kinase. This all stuff correlated with the renal phenotype, including bilateral agenesis, which is very, very important, really severe form, right? Bilateral aplasia or hypoplasia, bilateral agenesis of kidney. And this is including double kidney, hydrolytic, etc. And you don't need to remember all these things. You just know it's every different races have different genetic mutation condition. Especially BMP4 is including the hydronephrosis and dysplasia as well. So in the congenital anomaly of kidney and urinary tract phenotype is in 53% of BMP4 plus minus PUPs. So they got 60% of kidney hyperplasia and dysplasia, and 32% have UVJ hydronephrosis, and 8% with beef diuretic or double kidney, which is plus is 100% have anomaly. So if you have mice and you knock out this gene, 100% mice have one phenotype of kidney. This one as well. You got some mutation of SIX2, the gene mutation. The mutation, then you can see the ultrasound finding. In the mice have a lot of disease like this cystic dysplasia, hypoplasia as well. You can see that every kind of disease. So it can easy to induce the mice. Yeah. Okay, this is a lot of normal mutation. If you have some family, you found something with linkage analysis, then you can find something special from that special phenotype. Then you can do the genetic testing. If you found very, very important, then you can have a very good paper publications. Yeah, even just one family. So it's from the beginning to the end. You can see every kind of place, different origin, different genetic condition, all in a list. So it's also a case of ESCAPE study. It's 99 patients with kidney disease problem. So they got 5 significant genes: PAX2, EYA1, S61, SL1, and HNF1B. These are 5 important genes. Okay, severe prenatal renal anomaly associated with mutation with this PAX2 or HNF1 beta analysis in 91 family with termination of pregnancy because of severe congenital anomaly of kidneys. So if you got fetus in this mutation, most of them termination of pregnancy. And this is tissue-specific transcription factor and expressed in pancreas, liver, and kidney. So in the kidney, expression observed in the developing ureter and the tubular system. So first mutation in human HNF1 beta gene identified in patient with MOD5 and also renal cyst and diabetes. So that's why we call it kidney, renal cyst, and diabetic syndrome. So this is quite important factor. Okay, the other paper in the mutation TCF1-2 mutation also report is around 30% with predominant cyst. This is the other report. So this is the other report with 104 patients with congenital anomalies. So if you have this gene mutation, you got 81 patients with renal hypodysplasia, The other 39 cases with kidney dysplasia or with cyst. 9 patients with this present mutation, all dysplasia with cyst. Oh, you can see the percentage is very high. This is the other cases using the other gene detection. So this is positive for the HNF1 beta gene mutation. Then you got whole gene deletion is 83%. And 34 out of 62 are ARPKD and ADPKD and tupel positive. Okay, this is a clinical example. It's a renal cyst here. It's a very, very big cyst. Prognosis is very poor in this one. So now we also need to do the extrarenal malformation syndrome detection. We found not only kidney, around 28% have something multiple anomaly associated. It's not only solitary in the kidney, like in the heart or inner ear, diabetics, eye, mental retard, well, bone disease, GI. It's everywhere can be associated with kidney. So this is quite important slide I would like to share. Genetic testing in kidney dysplasia, we got some tools. The first one is sequencing. You got some hotspot. For example, you got HNF1 beta or PAX2 or the others. You got family history. Then you would like to know if that happened again. You can just sequencing the hotspot, targeting sequencing. Or you can do a diagnostic panel. As I say, some company have the panel of like whole 10 hotspot genes, including all the reported genes. Or the other company have different panel. You can do the panel. But if you want to do the whole exome sequencing, which is in selective case, in less selective case, it's you can't find anything, and you have a strong family history, so you can just go for whole exome sequencing. But it's very expensive, and it's not guarantee 100% guarantee you can find the mutant gene. So in this genetics, we got some conclusion. The phenotypic spectrum of this kind of disease is very broad. The renal prognosis largely depends on phenotype. So the prognosis could be very nice, could be very worse, very, very bad. So family history is positive in about 10 to 15%. Most model studies support genetic contribution. And mutation in PAX2 and HNF1B seem to be relevant gene cause. It's the most common to target hotspot gene in a patient with congenital urinary tract anomalies. So especially high detection rate of this gene mutation in bilateral cystic dysplasia is 22 to 25%. It's like 1 in 4. And also hyperechoic large kidney in around 30% in antenatal ultrasound. So renal function and prognosis of renal insufficiency can be very variable also with the same family. So the family analysis of genetic counseling is very important with patient with this kidney disease. It's not like gastroschisis or omphalocele, it's completely different. If you have the patient diagnosis with kidney disease, you really should ask the family member, maybe the relatives you can ask. Maybe you can have some clue if they have some novel mutation gene, then you can detect. So if you look into this special family, right? This is a genomic wide linkage analysis using NGS in family with a breast outflow obstruction. You can see the whole family have the breast outlet obstruction with oluto. Then this family are very worried about it, so they want to do that linkage analysis. They can only do linkage analysis. They can find the mutation. Otherwise, this is a strong family history right here. Yeah, this is the other mutation in, this is quite M3, acetylcholine receptor, CHR3, M3 mutation. Okay, if you knock out the mice, this gene, you can see the megacystic, and you can see also hydronephrosis, and also you can see the impaired eye reaction to light. So this is the paper published 2000 in the PNS, which is very, very nice job. So you found some gene, you knock out the mice, then you see the phenotype. It's like in human. If you don't have this gene or you have a mutation, you will have very similar. You got megabladder and hydronephrosis. Okay, this is the gene. And the other genetic disorder is also the M3 acetylcholine receptor. Also, the major receptor of bladder contraction. You can see the bladder is like this. It's poor bladder function. You cannot have normal urination. The only thing you can do is just put the urine catheter, and the eye cannot react to the light. In the last bit is like diagnosis, differential diagnosis of CAKUT syndrome. It's urofacial syndrome. It's mutation in the other genes, and this is published. So this is CAKUT syndrome related to HPSE mutation. It's different, but you can look. It's a facial with urofacial, urine facial syndrome. So they got problem with kidney and they got problem with face. Yeah, it's quite tough. Yeah, but just any problem? Any questions? And if you have any problem, you can just email me. And if you want to do international clinical attachment, we are very welcome. Last year we have a clinical fellow from Malaysia. This year as well from Malaysia. And if we have some update of fetal surgery, and I will pass the information to everyone, and you can just email me, and I'm very happy to reply. Yeah. I only want to talk about the genetic panel.
The reason why they included the gene in the panel, because there is one study that has been done where they found a certain percentage of mutation in one gene, generally one gene of interest, that has not been repeated by other centers at all because it's very costly analysis. So you can imagine that the scientific basis to apply it on all type of patients in different countries, very difficult because, as you understand, this group is very heterogeneous. Sometimes definition we follow is not the same. So one has to be very cautious. Again, I would say today what you can do that is not too costly is do the chromosome analysis, and if you can do the array, even better because you find the microdeletions there. Next is which gene we should do, and here we cannot do only one gene because it's so heterogeneous population in this group, so we have to do some kind of genomic approach. Genomic approach means that you have either to target a number of genes, or you look at the gene panels, many genes, or you look at the all exome, all the active gene we have. And you can understand this is like looking at the whole karyotype. You know, we look at all the chromosomes to be sure. And you can see how difficult it is, because even for karyotype, for example, even after birth, when we have opportunity to examine the children and so on, even for many chromosome aberration, which is not 100%, we find something for karyotype. So you can imagine for gene, when you look at thousands of genes or the whole genome even here, so how good it is the correlation. We don't know, we should why. And until we have a cheaper approach, it's the only way we have try to find something here. So many times it will be based on family history. Of course, the chance is higher if you have already a previous family history or something similar happening. And of course, in those cases, we will put a higher effort to try to find which gene, because it can have this particular family. It's a very costly approach too, because looking at all the genes or even a panel of genes, the panels of genes here is not 1 or 2 or 3 genes, it's sometimes hundreds of genes. So what we do in Sweden or many places in Europe is we do the whole exome, but we analyze not the whole exome. We analyze a set of genes that have been published with those type of defects. But if we don't find anything in the set of genes like panels, we have the data already done on the exome. Then we can target other genes, analyze deeper the other gene. And for example, after birth, if the baby dies in what, we may have data from the pathologists that help us target which genes to analyze that we have not done before. But the cost is already done only once. We do the exome sequencing, all the genes, so, and we target a number of genes like in the panels and hope to find something. But if we don't find anything, it's already analyzed. We don't have to repeat because the cost will be even increased. This is the cheapest approach to it. But I don't know if it is available in Vietnam to do that yet. I've not heard anything about this. But in many places in the world now we do this, the centers where we can do this analysis. So the last word is not to say, of course, about this. We need much more, we need to collect the data on much larger population to at least say, okay, if you target something, like in medicine, we should target the most frequent one, of course. And then, of course, we cannot do everything. So if in the near future we hope to have enough series that can say, okay, we can say the 10 most frequent defect gene we should target. Maybe those one is the one offered clinically. If you do research something else, you want to find as much as possible, so you do it very wide. But if you do clinical work, you say, okay, I can look at the most frequent things. So I cannot look at everything, because it will be too costly. Yes, as written here, the family history is quite important. The family history is quite important because there's a family history for that here. And as you can see, they are autosomal dominant inheritance. So that it means that in the new pregnancy, it can be as high as 50%. And of course, if you see there is a family history of could be dominant, then you have to look at the parents. Generally, those families have to be referred to geneticists because you cannot do it yourself. See?
So this slide I showed
Yes.
current method, but I don't think the array itself
No.
because it's all genetic condition.
Yes, but I mean the array is for chromosomal defect. So it is not here.
You need to rule out chromosome defect first.
Well, you see, the most costly way to do it is this way. Sequential testing is the most costly. Why? Because it's a candidate approach, candidate gene. Or it can be this gene. Okay, start with this gene. Then you pay for this gene. Or it's not that because it's normal. So we take the next one. And every time you have to pay. So three analyses cost as much as the exome sequencing. That's the reason why most places where we can do the exome, we do the exome. But we don't analyze all the genes in the exome. We analyze maybe those who are known to be associated already. It's 100 genes, for example. It's easier to do because it's faster for the bioinformatician to do that. Otherwise, the analysis can take 3 months to analyze. You see, so much data. But if you do the exome, the advantage is the sequencing is already done, the data is already there, but it's not analyzed. That's it. So what you do, why you don't analyze the whole exome? Because it takes so much time. It is what is costly today. Today is not the technology of sequencing itself that is expensive, because the cost has gone down because it's automated. See, the cost of sequencing has gone down all the years. So we are now, for the exome, we are about to cost maybe 2,000 euros, for example, or 1,500 depending. But the cost that has not changed or even increasing is the cost for the bioinformatician, because those people are not very common. And the good bioinformatician who are trained in the clinical part, not only in the research, the clinical part, they are very rare. So everybody fighting for them. For example, in Sweden, Finland is trying to get the Swedish to Finland by paying more. Norway, the same thing here. So this is a fight for those who are rare and needed, you see. Because if you have a company doing this, you need the people to analyze it, so you will pay more to get those people there to you see. So in Europe, we've been stealing from each other, you know. I will hire someone from Germany or Poland, meaning that in Poland there will be less of them there. So this is how we work right now, but it's not very clear. So the next, a bit cheaper, is doing a panel, but the panel gives you answer only on the gene involved. And because there are so many who are known, but even more maybe who are not known to be associated, because we have not done big studies about this. So you pay here, but if the result comes normal, then if you want to do the next step, what is it? It is this one exome. So you have to pay again the sequencing. So that's the reason why we started with the exome, but we analyze like a panel. Because we have done the sequencing, but we analyze only a number of genes. If they are normal, the sequencing is already done and paid here. So we can increase to look at other genes. This is why the most economical way maybe to do that is to start with this whole system here, but reduce the analysis to a panel to start with. If we're lucky, we find something. If not, we still have the data. The most expensive is this way. That's the reason why very few studies were done before, because it's what we call the candidate gene approach. Because each time you pay for an analysis, and 3 or 4 analyses like that cost as much as doing the exome. So better to, and the chance you find something very little because there are so many involved. So except if from the ultrasound, it's very clear what you can suspect a few genes, like if you see not multicystic, but if you see polycystic kidneys on the ultrasound, then you suspect in the first hand a polycystic kidney disease. And those you find the polycystic kidney disease, you find an ultrasound of the recessive type. And there's very few genes. Then it may be better to test directly the gene that is known to be associated with polycystic kidney disease. But in most situations, it's not so simple. Most situations, you have to either choose this or this. Those people who started with this, it's cheaper to do this than that. Yes, it's cheaper if you find something, but if you don't find something, it's more expensive. And you understand that it's not easy, even if you do a panel that is several, 200, 300 genes, you may not find anything. Because if you're looking at the wrong gene, of course it will be normal. Because we don't know better than that here. So I suggest if you're looking in the long term and you build up a genetic lab, so the equipment will exist for sequencing in the future. But to do this, today the cost will be already covered because when you buy the machine is there. And the cost to run this and to run this very similar in terms of chemicals. So not very big difference. The cost will be different because of the bioinformatician. In countries like Vietnam, the salary of doctors or bioinformaticians not as high as in the Western world. So the cost may be less in a country like Vietnam in the future. And maybe in the future, sample will be sent to Vietnam from countries where the salary of bioinformatician will be very high. And we see this already in China, a country like United States, and the famous Children's Hospital of Philadelphia, SHOP, they're sending all their genetic analysis to BGI in China. Why? Why they are in Philadelphia, next city, Boston, where you have the highest concentration of high-tech company in genetics. It's because it's cheaper. It's cheaper. And they're very good because they've done it from the beginning. So they send it to BGI because it will be cheaper for them. The technology is exactly the same. They're using the same machine before and so on. So even the Americans, big centers like SHOP, are thinking economically. Well, today the most difficult is not to do sequencing, it's to interpret the sequence. That is what we will keep the West work. How to interpret the results. That is the difficult thing now. Sequencing is like the machine will do it. So I think
and edit some more. Yeah. The UK group led by Lin Chiti, you must know very well, right? They just published a very important paper in Nature last month in February 2019. They using the whole exome sequencing to do around 500 cases in UK to see if they have additional anomaly compared to array and karyotyping. So the first generation will be the karyotyping, right? You have ultrasound anomaly. But we already know if you do the array CGH, you will have another like 6% more additional finding compared to the karyotyping. Then they found this whole exome sequencing. If you put on the first line, then you will find additional more, of course, because it's just like shotgun, everything, screening everything, yeah. But it's still very expensive right now. But they got a big grant.
Yes, I know because I was the reviewer for them. So I know that they did this study because the Wellcome Foundation gave them the money to do that, and I was the reviewer for the Wellcome Foundation. Even more than that, the paper from Lin Chiti is from the Nijmegen group that did a very smart study. They started to take a group of patients where they did first array, and they found 15% of causative mutations with the array, and the rest were normal. So they took the one who are normal, the normal arrays, but still had the symptoms, to do whole exome sequencing, and they found about 40% together with the array. Still, half of them we cannot find the cause, the genetic cause. So they went further even in this group, and they looked at whole genome sequencing. So we don't look only at the known gene, but we look a bit deeper at introns, between the active component here, and they found another 20%. So, of course, if we look deeper and deeper at the genetic setup, we will find the cause. But, of course, we cannot offer to every patient to do whole genome sequencing. But in my hospital, where the state is paying for those, we do 3 to 4 whole genome sequencing on patients. Not research any longer, it's on patients, because nobody can come up with the cause. And there are several causes in the family that have been affected. So we decide, okay, we can do that here. So yes, of course, we can always go with higher resolution, but the problem is we cannot apply it to the whole population of affected babies. It's too expensive. Even in the rich world, it's too expensive. So for some disorders, you will listen a bit later, because we have a lecture on skeletal dysplasia. We have an approach. All the gene known for skeletal dysplasia now is on the first line. We screen all of them, sequence all of them. So we should find most of the mutation in the first line. But even that is not 100%. Because why it's not 100%? It is because we don't sequence everything. I mean, in between the two exons, or several exons, I mean the exons are the active part of the gene here. There is what we call introns. Before we thought that the introns contain no data. That's not true. Now we have more and more evidence that even in the introns deep, we call it deep because we don't sequence these parts, or very short parts of it. Are sometimes mutations there that explain the defect. But it means that we cannot find, even by what we call sequencing today, we cannot find all the defects because we don't sequence in between. Or very short segments we do that here. That's the reason why we cannot find all the mutations, because it's hidden deeper in the genome. And you can imagine already when we do whole exome sequencing, it's millions and millions of data in such a way that even a hospital like Karolinska Hospital, which is the largest university hospital in the Nordic countries, we don't have the infrastructure in informatics to take care of all those data, because it's millions of data per patient. You can imagine if you have many patients here, where shall we put all this data? So we have to use the computer facility of the University Karolinska Institute there. Fortunately, it's across the street, so we have, through cables, we can use the computer, the big computer of Karolinska Institute. Otherwise, nearly no hospital have those infrastructure, because before in medicine we never had so much data to take care of. Millions of data when you sequence. See? So I would say today at least the chromosome is still the standard, because, and the chromosome means also the array, because array is replacing more and more the karyotype. And on the pediatric population has completely replaced in many places as a first line analysis. So in many countries, the first line of analysis no longer karyotype on the pediatric population, it is array. At least. And then if you have some kind of molecular facilities, depending what they can offer, and how much it will cost, you know. If you have patients who decide, okay, I want to do everything here, then there is a cost, and there is of course that's reason why companies are coming in there. They say, okay, we can do everything here, but it has a cost. And today there are nearly no healthcare that offers everything on every patient, because we don't have any cost-benefit analysis on that here. And in the countries where the healthcare is free, they do a cost-benefit. Is it worth to do? And if there is no evidence it is worth to do, then they will not offer it to the public. Okay. Question, please. So, the question, you understood that as a clinician, you have understood this with genetics you've heard many years in Vietnam. Is more better? We know that today, not always better to have more. Because if we have more, we can interpret that's good. But if you have more, we cannot interpret, we're confused. And you know this by yourself here. When your patient were even, you can do this, and they don't know what is better, they ask the doctor doesn't know even that because it's marketing here. So more is not always better in genetics. Because if it is more and we can interpret, that's good. If you cannot interpret it, sometimes it's not so good here. We confuse more. Especially when it costs money. So it shows again, because the technology is going so fast that in a country like Vietnam, there should be, for the genetic analysis, it is clear, you understand, it is clear when you see this. Every center cannot have a center like that in genetics. It's impossible to have the knowledge, the skill to do this type of work. Some central laboratories should be able to do this, and then it has to be referral from the other laboratories. This is how to build up the whole thing here. We cannot, every laboratory, every hospital cannot have a genetic lab that can do all this. It's impossible. You cannot find the people, and it would be too costly. And when they try to do that, I've seen it so much in Vietnam, they buy the machine and nobody's using them because nobody know how to use them, or it's too costly to use them. So it's the waste of money many times. Better to centralize a little bit and to be able to do numbers so that we reduce the cost for analysis. But it's very difficult for hospital director to accept that because it has been like that in Vietnam for so many years, so that they understand it when you talk to them, but still they will not make any change. Okay, first day. So this is the main problem. So in my view, if you're doing something like exome sequencing or even panels of genes, it should be part of the protocol. So a research protocol. That is, one day you intend to report that a series of cases, and those are not so common, so that we can have big series. So the only way to resolve the whole thing here is to create very big database so that we can add patients and results on that here. And many efforts have been done internationally to try to gather all this data in one database. But you know how it is. It is as difficult to work between two hospitals than you can imagine when we work in different countries like that here. Everybody wants to be me. My protocol, I'm taking care of the register, and so it will take years before we can get results. So unfortunately, I cannot give you a clear-cut answer. Okay, if you can afford to do those analyses, you do it, but then comes the next problem: how to interpret the results if you find something. And sometimes it is on genes that have never been associated with this postnatally. So how you find something that in silico, I mean, using software that predict an effect on the protein, for example, on a gene. Yeah. So it could be clearly predicted as pathogenic, but no case have been described before. So what do you tell the parents? Should you stop doing putting a shunt? So the difficulty in genetics now, because it's going so fast between the new development of technology, that we don't have the population data. And you can imagine to have, say, in biochemistry, to use the biochemical assay, and you don't have a normal reference. It's completely crazy, of course, to apply it. But in genetics, it's done daily, because the company are pushing so hard for the technology, we don't have the data. And data and genetics, as you know, is not very common. So if you do, you have 100 control, it's nothing, because something in genetics happens in 1 in 1,000, 1 in 10,000. So we need very big data. And the only data we have of this size are coming from other population, from the rich country, like in USA and so on. And when they have done maybe the 1,000 genome and so on, but very little data from a country like Vietnam and so on. So technology is good, but when we can use it based on evidence, and it will take a long time before we get enough data. So it's not because one case has been described with associated with a change, a mutation, or what we call nowadays a pathogenic variant. It doesn't mean that we have to apply it on all the population, all the cases. You see, we have very little data, so I cannot tell you exactly to do. If you ask me exactly what is your clinical practice today, so I think that most people will agree that we should at least do the chromosome analysis. And more than chromosome analysis, if available, an array. Because we can look at all the unbalanced chromosome karyotypes that way. So that would be the first step, because it's easier to interpret the arrays, because so many arrays have been done in the postnatal population. So we know most of the normal variants and so on here nowadays. Second, if we choose to do a single gene analysis, why? Then this I cannot give you a perfect advice, given it is only the only science you can see. Yes, you can apply the wide approach, gene panel and so on here, but it's looking like you're shooting in the by chance, you know. And then you will get some results interpreted. Is it associated with that or no? Don't know for sure. So you can get a real headache to use something. That's the reason why many people are using clinical exome, that is only on cases that have been associated with that here. So we forget the possible variants that we can find that we cannot interpret. That's one way to look at it, yes. Maybe making it simpler for clinicians to work with that. You are using a clinical array, clinical exome. Can you comment a little bit on
that? Về cái clinical exome sequencing thì hiện tại thì ở tại Hùng Vương kết hợp với lại bên cái nhóm nghiên cứu ở bên Gen Solution thì cũng đã thực hiện được một số trường hợp thì bắt đầu thực hiện thì cái việc mà cái quy trình mà khi mà làm đối với những cái trường hợp mà có bất thường trước sanh hoặc là sau sanh đó, là chúng ta phát hiện ra những cái bất thường trên siêu âm hoặc là bất thường bên ngoài mình khám được, ví dụ có chậm phát triển trí tuệ hoặc là có những bất thường mà nhìn thằng cái bên ngoài, thì cái bước đầu tiên chúng ta sẽ đi vào cái CNV, tức là làm kiểu như một cái microarray để mình thực lên xem nó có bất thường về microarray trước hay không, để chúng ta loại bớt những cái bất thường. Thì trong những cái bất thường của những kẻ sau sanh nó chiếm khoảng 3%, thì trong đó nó chia làm 3 phần, một cái phần đó là bất thường về sắc thể, chúng ta làm cái carotid để chúng ta chẩn đoán, ví dụ như PCM1 nó nằm trong 1% đó, và những cái microdeletion nó chiếm 1% của những cái trong cái 3% đó, và cuối cùng đó là sequencing. Thì khi mà chúng ta không có những cái bất thường về bất thường về sắc thể, không phát hiện được bất thường microdeletion hoặc microduplication trên CNV, thì chúng ta đi tiếp tới cái bước thứ ba, đó là bước của sequencing. Thì sequencing thì hồi nãy thì Hùng cũng có nói là rất là khó khăn khi mà chúng ta làm Thì nếu mà chúng ta chỉ chọn một gene không thì rất là khó. Thì nếu mà làm một gene thì nó sẽ âm tính, ví dụ nó âm tính ra thì mình sẽ không biết là mình đi tiếp tục như nào nữa. Thì cái bước là làm sequential gene, tức là làm rất là nhiều gene, 2 gene cho một cái CAKUT như giống như vậy, hoặc là CAKUT thì có thể là tới 100 gene, trăm mấy gene. Thì khi mà làm cái panel đó nó mà lỡ nó âm tính nữa thì mình cũng không biết là làm gì tiếp. Thì khi đó thì chúng tôi cũng lựa cái phương án là mình sẽ đi clinical sequencing hay giải hết 20 mấy cái 22.000 gene. Thì clinical sequencing sẽ lựa khoảng chừng 4.500 đến 5.000 gene để mình làm, để giảm bớt những cái variant mà nó không có ý nghĩa. Thì thật sự thì khi mà làm ra thì đúng là nó sẽ có rất là nhiều cái thứ variant xảy ra. Thì lúc đó thì nguyên cái đội phải ngồi dò lại tất cả những cái lâm sàng, tất cả những cái y văn như thế nào nó có phù hợp với nhau. Thì cũng may mắn là một số trường hợp nó ra nó khớp, ví dụ như là có những cái trường hợp nó bị bất thường an bạc thì có thể là tìm ra những cái gene FGFR tuy để nó ra dương tính ngay lập tức yêu cầu để cái đó thì mình đưa ra nó phù hợp với lâm sàng. Nó sẽ có một số trường hợp ra nó không có những cái gene pathogenic mà mình nghĩ tới. Mình sẽ đi tiếp những cái tìm trong những cái gene, cái variant mà nó nằm trong nó gọi là cái VUS, tức là cái variant insignificant. Nó không có rõ ràng trên lâm sàng. Lý do không rõ ràng trên lâm sàng là do cái việc mà người ta publish nó chưa có đủ, nó chưa có liên quan giữa cái gen và cái hình với nhau. Nó chỉ được chứng minh trên silico, giống như là thầy Hùng đã nói là trên những phần mềm predict cho cái gen, cái variant đó nó sẽ gây ra một cái bệnh tổn thương rất là nhiều đối với một cái protein. Thì mình sẽ có một cái VUS mà khi mà trả lời để tư vấn một cái VUS cho bệnh nhân, mặc dù nó có liên quan đến những cái bất thường mình đang nghĩ tới, thì nó sẽ cũng rất là khó khăn để mình tư vấn cái trường hợp đó. Thì nó sẽ tất nhiên là mình sẽ đợi có những cái data lớn hơn, mạnh hơn, nhưng mà trong thời điểm này thì chúng ta vẫn phải làm để mình tu tập càng nhiều cái data thì sau này mình làm mới càng dễ, còn nếu không thì rất khó làm.
Because you have to understand that although genetics have been progressing very much, one thing we still in the early stage of what we call functional genomics, meaning that it's one thing to know a gene, it's another thing to know what is the function. And in the body, the gene do not function alone, so they function with other genes, you know. And this we know nearly nothing. The interaction, gene-gene interaction, we know nearly nothing. So even if we find sometimes that the function of a gene is decreased, it might be pathogenic if this gene has interaction with other genes. But today we know nothing about it, you see. So it's very difficult because we have to understand that, of course, it's like in physiology. If we start to understand the function, it's easier to understand how things happen. But if we don't know the function of a gene, and most of the genes we don't know the function, as a matter of fact. We can say, well, we know that there is a gene and we can predict the protein, but we don't know what is the function of it, you see. So it's very difficult from this data to interpret how is it on your patient, what does it mean. You have to remember, even today, for Down syndrome, we don't know exactly why we have from trisomy 21, we have a phenotype like the Down syndrome patient. We don't know exactly, you know, what is happening in the terms of function. Why would you have a defect of language? Why the tongue is big, for example? We don't even know this, you see. And it is the most common, the earliest chromosome defect we have known. So our knowledge is still very limited in terms of functional genomics, function of the gene we are working with. We learn about the function when we have a patient with a defect, and we can associate the the defect. So we learn, like everything in medicine, by when it is not normal. We don't know. We don't learn from the gene itself. We don't learn how is the function before we have a patient with something. So like in beta thalassemia, we have understood the function of hemoglobin first when we have patients with defect of the hemoglobin. But before we have the structure and so on, but we don't know what is the function of it. We learn the physiology of hemoglobin by the patient with defect. So we don't learn through the normal patient, we learn from the defect patient. And you know, you can imagine how difficult it is to have patients with the same gene defect in enough of cases to understand the function of it. The cystic fibrosis, yes, because there are so many of them, we started to understand the function of it here. But many genes, we don't have so many patients. So it's very difficult to make the association, what is this gene doing? Because sometimes it has importance in development, but later on maybe not the same function or importance. So we don't have a chance to understand what the gene is for. So although, I mean, I know that companies and even medicine people are pushing what's high tech, you know. Okay, look at all the chromosomes, yes. We look at all the genes, yes. But then how do you interpret it, you know? It's not easy if you don't have even basic data as population data.
Thank you, Tentel. So we keep going to the last bit of the kidney disease. This help will be a bit